brief introduction. Dr. Steve Hollon, he barely needs introduction. Everybody probably knows him. He's such a well-known name in the field of psychotherapy research. He's a professor of psychology and psychiatry at Vanderbilt University in Nashville, Tennessee, and he's an international recognized expert on the theory and practice of cognitive therapy for depression and has written over 100 articles on this topic. Broadly speaking, his body of research has focused on the process of cognitive therapy and its comparative efficacy to psychopharmacology and other psychotherapies. And he will be speaking to us today about the mechanisms of cognitive therapy that may potentiate long-term symptomatic change, resistance against relapse and recurrence. And we're very happy and honored that he's here today to join us for this webinar. Dr. Hollon, go ahead.
Thank you very much, and good day to all of you, mornings, afternoons, evenings, whatever it is, wherever you are. I thought we would talk today about the treatment of depression, and I thought we'd talk today particularly about cognitive and behavior therapies, the cognitive behavior therapies, particularly with respect to how they stack up relative to medications. The first slide I wanted to bring to your attention, in the United States, the American Psychiatric Association has done a successive series of guidelines, and the one I've cited comes from the year 2000, but the most recent update, 2010, carries the same statement, virtually unchanged. And what the American Psychiatric Association would say is that although depressions, and I'll be talking primarily about unipolar major depression today, although these comments would extend certainly to other kinds of non-bipolar depressions and perhaps to the depressed phase of bipolar depressions as well. But that, according to the American Psychiatric Association, if you have patients who are clinically depressed and more severely clinically depressed, and we're not necessarily talking psychotic, we're just talking more severe major depression, what they would say is that antidepressant medications really need to be provided for those patients, unless perhaps it's so severe that you need to use electroconvulsive therapy, ECT. And they go on to say that although there's some data that suggests that some psychotherapies like cognitive behavior therapy may be effective for such patients with moderate to severe depressions, for patients with more severe depressions you really need to add medications. And that's been pretty much the position in the American Psychiatric Association. That's pretty much the way most practitioners in the field have kind of assumed it was going to work, and the data I want to show you today suggests that may not be as true as is generally presumed. What I'd like to do is talk first about acute response, and the basic question here is, can cognitive therapy hold its own with medications in the treatment of even patients with more severe depressions? I'm going to tell you about a study that we did, published as DeRubis et al. Was the first author back in 2005 in the Archives of General Psychiatry, and the project was intended to look at exactly that question for patients with more severe depression, all of whom met criterion for major depressive disorder, and with the exception of screening out patients that had histories of schizophrenia and patients that were currently psychotically depressed, we had really minimal other exclusion criterion. We had a total of 240 patients, and of those patients, about 2/3 met criterion for other Axis I disorders, most of the anxiety disorders, but a scattering of other things as well, and about half met criterion for a Axis II disorder, personality disorder. So it was a sample, all of whom were depressed, and 2/3 had other kinds of diagnostic disorders, non-psychotic disorders, and half had met criterion for Axis II personality disorders. Now, the thing we did do was to screen out less severe depressions, all again major depressions. So we took essentially we used a Hamilton rating scale score of 20 or above to operationalize greater severity, which means we probably picked up a little less than half of the patients that would have met criterion for major depression. So it was more severely depressed, the kind of sample that would typically show up in a pharmacology trial, placebo-controlled pharmacology trial. Those patients we then randomized to one of three conditions. The top bar indicates a cognitive therapy condition, abbreviated CT. We've got an N of 60 patients we randomized there, and those patients met with the cognitive therapist in individual cognitive therapy over the course of 16 weeks. Typically for us, we would start with 2 sessions a week for the first 2 to 4 weeks. It's so difficult to get a depressed patient moving unless you see them more frequently in the beginning. They meet, again, usually twice weekly for the first 2 to 4 weeks. Weekly after that, over the rest of the 16 weeks, with maybe a little bit of spacing out near the end. Over the last 12 through 16 weeks, you might drop back to every other week sessions, just so people got used to the process of the therapy wrapping down. And the cognitive therapy is really quite standard cognitive therapy, focusing primarily on getting the patient moving in the beginning, some more behavioral kinds of strategies, graded task assignment, that kind of thing, and then increasingly focusing more on the beliefs that they had, specific negative beliefs about the self, the world, and the future in the middle phases, and then in the later stages of therapy, paying a bit more attention to core beliefs and the kind of basic notions the person carried about themselves, which often we think of as being kind of risk factors. The second condition, ADM, stands for an antidepressant medication, and in this trial that was paroxetine. We wanted to use an SSRI, and we wanted, among the SSRIs, to take the one that had the best data for efficacy with more severely depressed patients. And although there's not a lot of difference between them, the best existing clinical data at the time was in favor of paroxetine. Those patients that were assigned to medications worked with a pharmacotherapist, psychiatrist in most cases, occasionally a psychiatric nurse. They were usually seen weekly over the first 4 weeks of treatment and drop back to every other week after that period of time. Shorter sessions usually, focused more on clinical management, focused more on dealing with side effects, and some limited support, but no formal psychotherapy. At the 8-week point, patients who hadn't shown us a response on the medications were augmented with a second medication, either lithium or citalopram or dizipramine, at the choice of the prescribing clinician. We broke the blind at that point, and they were then continued on medication. And as you can see, about slightly less than half of the patients needed to be augmented. The third condition was a pill placebo condition, and that was identical to the second condition in the sense of meeting with a clinical pharmacotherapist, having the same schedule of meetings, etc. The only difference is instead of the active medication in the pill, it was an inert milk powder that they got. The contrast between the active medication, the ADM condition, and the placebo condition was triple blind. The patient didn't know, prescribing clinician didn't know, and the independent evaluator didn't know whether somebody was getting active medications or not. The comparison between either of the two pill conditions and the cognitive therapy condition at the top was a single blind. In that case, of course, the patient knew and the therapist knew that the person was either in cognitive therapy or in one of the two pill conditions, but the independent evaluator didn't know. So we had periodic assessments, weekly in the beginning and then back off to every other week after about week 4, where we'd monitor on good standard clinical rating scales like the Hamilton Rating Scale for depression, which is the primary outcome measure I'll be talking about today, but also getting retrospective assessments on the life for any of the periods of time between the Hamilton ratings. That's basic study design. What I'm going to go on now and show you are the acute treatment data from that trial. And on this slide, on the y-axis, I've got percentage of patients that met our criterion for response. And in this case, we're defining response as a Hamilton Rating Scale score of 12 or less at that point in time. And again, we're talking first about the 8-week period of time. So this is the proportion of patients who met a pretty reasonable standard definition of response. And of the patients that were randomly assigned, half of the patients assigned to active medications met that criterion. 43% of the patients assigned to cognitive therapy met that criterion, and only 25% of the patients assigned to pill placebo. The medication placebo difference is significant. The cognitive therapy placebo difference is significant. A small difference, not significant, between the active medication and the cognitive therapy, the red bar and the blue bar. What we conclude from this is that I should mention that the study was done at 2 sites. It was done at University of Pittsburgh, which is the original home of University of Pennsylvania, the original home of cognitive therapy, and Vanderbilt University, which is where I was located. Rob DeRubis oversaw the cognitive therapy up at Penn. I did down at Vanderbilt. DeRubis and I were also one of the 3 therapists in each of the 2 sites. Our pharmacotherapists in the project, Jay Amsterdam, oversaw medications at Penn. Rick Shelton oversaw the medications at Vanderbilt, both highly regarded, highly respected psychopharmacologists. And we basically pushed the doses very rapidly and quite high, so we have great confidence that we didn't undercut the quality of the pharmacotherapy. That being said, cognitive therapy basically held its own with medications, both superior to pill placebo condition, in exactly this kind of patients that the American Psychiatric Association would say need to be medicated. Bottom line, we think, is if you do cognitive therapy well, you get pretty much pretty close to the same kind of response you get from medications. The two right-hand bars at 16 weeks, you could have put one condition on top of the other. A little faster response to medications than cognitive therapy, but by 16 weeks they were virtually identical. Again, I think reinforces the point that if you do your cognitive therapy with reasonable competence and reasonable frequency, you're going to get about the same kind of response that you can get from medications, even among patients who are indeed more severely depressed. Next slide I want to show you is a slightly different outcome measure. Despite the fact that the two active treatments, the medications and the cognitive therapy, produced about comparable change in depression, we did have a differential impact on functioning, in this instance indexed by employment status. On the across the top, you see we have three bars. The blue bars for deteriorated; those are patients whose employment status deteriorated across 16 weeks of treatment. The yellow bars improved; those are patients who, if they came in unemployed, got jobs. If they came in with part-time work, they moved up to full-time work. And the green bars, the net change, the differential of the improved versus the minus. In the medication condition, despite the fact that we had good change in depression, about close to a little over 60% of our patients got better over the course of treatment. We didn't get that much change, at least that much net change in employment status. On the cognitive therapy side, what we see is close to 20% of the patients improved their employment status. That's significantly different from the medication condition. And given that only about 20% of our patients were unemployed in the first place and a few more underemployed, that's a pretty good amount of change for that. It held across the 2 years of the follow-up, which I'll tell you about in just a moment. But in general, bottom line for me is when it comes to acute response, I think this study, and there are a couple of other studies in the literature that suggest the same thing, particularly Robin Jarrett's nice study in '99, suggests that if cognitive therapy is adequately implemented, it can hold its own with medications in terms of symptom reduction in the treatment of even more severely depressed patients. Psychotic patients I wouldn't go that far with, but in terms of non-psychotic patients with major depression, I think basically do it well and you get basically the same kind of comparable results. And you actually have a greater impact on functioning than you necessarily would from medications alone. Make you feel better, but not necessarily help you do better. Professor Zhang, were you opening the mic at this point for questions?
Yes, I have a question from Russell Hilliard. Let me open up the microphone. Russell, go ahead. I don't hear anything. I do not have a microphone, so I'm going to read it to you, Steve. The question is, where was placebo at 16 weeks?
Oh, we stopped the placebo after 8 weeks, and we did so only because there was no strong reason to keep it going. We estimated that we would get about that kind of response drug placebo difference, and we did among more severely depressed patients. We saw no strong reason to continue, and those trials that try to keep folks on placebo for too long a period of time, it's you start to push up against the bounds of ethicality, and it's just tough to keep people from dropping out. Jan Fawcett, who oversaw the medication conditions and the NIMH Treatment of Depression Research Collaborative Project back in the Elkin study published in '89, oversaw the placebo condition as well, and said it was like pulling teeth, particularly for the pharmacotherapists, because if you have somebody that's not doing well, they're not sure what's going on, and it was a bit of a mess for them. So we didn't continue the placebo condition.
Okay, thank you. There's another question from Mary Cruz. I'm going to open up your microphone right now. Mary, you can speak now if you want.
Okay. Hello, can you hear me?
Yes.
Oh, okay. Yeah, this is Mary Crohn's. Yeah, this is very interesting. What was the quality of the CT that you think had this very interesting impact on employment improvement?
Unmuted.
Yeah. We did basically what you would typically do in cognitive therapy, which is to encourage people to use their own behaviors to test their beliefs. If somebody doesn't think that they could get a job, for example. We have them go through the steps that somebody would go through to apply for a job, to follow up in interviews, and then see what happens. You do that in a host of different situations. You might start with something as simple as getting a laundry done, getting a dinner cooked. Anytime somebody is hesitant to start doing things in depression, it's usually not that people can't do it, it's that they don't start. And so there are a host of strategies that use more behavioral, usually in the beginning, to get people moving. And we think those same basic kinds of skills help them when applied to the vocational domain. Sometimes the therapist is working on that with the client. Particularly if they're having difficulties in the employment domain, we work directly with them, and other times not. I think the two basic principles that I would think of with cognitive behavior therapy, first one is when in doubt, do, or rephrase that as don't wait to feel like something, just do it. If it's something that you want, carry out the steps anyway and let the outcomes decide. And it's useful to kind of get depressed patients unstuck. And the other basic principle is to don't believe everything you think. Just because you don't think you can get something that you want doesn't mean it's not worth trying. So we just keep working with folks and do that repeatedly. They build up a backlog of experiences where things typically work better than they thought they would. The old notion of depressive realism just isn't, frankly, accurate. People who are depressed typically underestimate what they can do, what their chances are, etc. And you just work with them over the course of 6 to 8 weeks, and they start amassing experiences where they do better than they thought, and then they start bringing that to bear.
Meredith has a third question.
Yes, just one quick follow-up. Gender split?
Go ahead.
Yeah, was there a difference in terms of males and female subjects?
Unmuted.
I'm sorry, no. We didn't get gender was not a moderator for us in virtually any respect, in terms of change in depression or in terms of employment improvement, that kind of thing.
Okay, I think that's it in terms of the question we have so far, so please continue. Unmuted.
Proceed? Proceed. What I want to talk now is what I think is the most interesting, the unique effect that you get from cognitive therapy, and I'll show you later on also from behavioral activation, and that's that it looks like it has an enduring effect. It looks like whatever you're doing with clients in therapy, either you're changing them in some way or they're picking up skills that they use after therapy is over. There's a lingering effect from therapy, and we'll leave that as an open question first. I want to show you the follow-up data from the study I just described, the Derubis trial. And on the far left, where it says acute phase, those are the data I already talked about a minute ago in the other two slides. Now we're going to pick up what happened to the folks that responded to treatment from that point on. And if you follow the top bar, the blue bar, of the 60 patients assigned to cognitive therapy, again, about 60% of them responded, so somewhere in the mid-30s, about 34 of them responded to treatment. And for those folks, formal cognitive therapy was basically over. They would stop having the regular cognitive therapy sessions with the therapist. We did allow an occasional booster session, no more than 3 sessions over the course of the next 12 months, no more than a single session in a given month. The basic notion is like when you send a child off to college, you don't immediately rent out the room. You hope that they're going to come home on vacations and see you from time to time, but you don't expect them to keep living there at home with you. And it's the same kind of analogy I would use here. So occasional touch-based sessions. And the therapists and clients did it a variety of different ways. Some would schedule periodic booster sessions. Others would wait and use them if they needed them. And as it turns out, only about a third actually used any of the booster sessions. So it was available, but not necessarily heavily subscribed to. Nobody did more than 3. In the middle set of rows, the patients that got better on medication, we did a second randomization. Half the patients stayed on randomized to stay on medications, and the other half were withdrawn onto pill placebo. This again done triple blind. Patient didn't know, prescribing clinician didn't know, the independent evaluator didn't know who stayed on active medication, who was withdrawn onto pill placebo, and we followed them again, still taking pills over the next year, the first year of that 2-year follow-up for comparisons. The patients in the bottom row, the folks who were treated with placebo in the acute treatment phase, as we mentioned earlier, didn't continue into the follow-up phase. They were provided with humanitarian treatment, either medications or cognitive therapy, whatever their choice was, and don't appear anymore in the data sets that I'll show you. Now we pick up on the 2 sets of patients. Those folks got better on cognitive therapy, the top row, the blue, or those folks got better on medication. They're divided in 2 groups. The red, who are kept on continuation medication, that's the current standard of treatment for what you would do for somebody who's recently remitted on medications, or the patients who were withdrawn onto pill placebo. which no psychopharmacotherapist in the right mind would do at this point in time. 20 years ago, 30 years ago, that's what we did, but nowadays we know better than to do that. But that's our comparison condition. We wanted to see whether or not the continuation medication prevented relapse and/or the prior cognitive therapy prevented relapse. Now, notice we have two phases here. The continuation phase is where the cognitive therapy patients can get an occasional booster session if they choose. The pharmacotherapy patients are all still taking pills, half on meds, active meds, half on pill placebo. And then at the far right, we have yet a third phase, which is the follow-up phase. At the end of the year-long continuation phase, everybody stopped everything. No more booster sessions in the prior cognitive therapy, and folks on pills, if they survived, even if they survived without relapse, were withdrawn from any kind of pills they were taking. The folks in the red line came off medications entirely. The folks who'd managed to survive in the placebo condition, if they still hadn't had a relapse, we stopped them having taking pills as well. Again, these data were published under Hollon et al. Again in the archives of Journal of Psychiatry in 2005. The data look is this. This is a survival curve. So let me walk you through how these things are interpreted. Now everybody's starting up at the top, because that means the patients in this phase of the trial, the 34 patients in about 35 patients in each of the three conditions are now essentially in remission. So they're not currently depressed. They're starting at the top, and as the line anytime the line drops down, that indicates that somebody's had a clinical relapse. We define relapse as return of symptoms for about a 2-week period of time. We were quite active to make sure that we weren't misinterpreting the simple discontinuation effect from the medications. Paroxetine can be a hard medication to come off of. So we had a fairly slow withdrawal schedule for the folks in the yellow pill placebo condition. We took that out over about a 6-week period of time. We also allowed patients to get rescue medication. Sometimes a single dose or two of fluoxetine will take the edge off of the discontinuation effect. And we, over that first month period of time, we required 3 weeks of symptoms to call something a relapse. So we were pretty conservative about how all of that worked. That all being said, notwithstanding, you can see the difference between the yellow line and the red line. The patients that were withdrawn from medications, the yellow on the pill placebo, the yellow line showed a much larger, more rapid rate of relapse over time. So by the end of the year, where that dashed line is in the middle of the curve, 80% of them had one or more clinical relapses in that period of time. The folks who were kept on medications, the continuation effect showed a good, solid, significant continuation effect. Only about half of them had a relapse over that period of time. This is a higher risk, more severely depressed sample with a lot of comorbidity, so the rates of relapse are going to be quite high in this kind of sample. But we basically replicated the standard finding in the literature, about a dozen good trials in the literature, that suggests that if you get somebody on medications, better to keep them on medication rather than taking them off shortly after they're better. Otherwise, you put them at risk for relapse. Relapse typically defines the return of the treated episode. So we have pretty good evidence here that medication may help you get better, but if you get better medications, stay on the medications, at least for a period of time. The little dashed orange line that you see is our estimate of how folks would have done had they stayed on medications. Not everybody who was supposed to did. We had a couple of patients in that condition that essentially were less than fully compliant with their medications. And anybody that took less than 75% of their medications and had a relapse, we censored at the point that they were non-compliant. So they didn't count as if they had a relapse. And the orange line is what would have happened if everybody who, in the red condition, the medication continuation condition, that was supposed to stay on medications, actually stayed on medications. And you'd see it would boost it just a little bit, not dramatically different, but somewhat different. The final condition to look at is the green line at the top. Those are the folks who are on prior cognitive therapy. Remembering now, those folks have basically stopped therapy. They can get no more than 3 booster sessions over that first half of the graph. And only about a third took advantage of any of those. And what we see is folks with prior cognitive therapy did at least as well, not significantly better, but visibly better than folks who were kept on active medications. And I take that as an indication that certainly looks like we have what we would call an enduring effect. If you get cognitive therapy, not only do you tend to get better and do as well as if you're on medications, not only do you tend to improve your vocational situation, but after treatment's over, you do at least as well as folks that stay on medications, and you do considerably better than folks that come off medications. We would say that at least 2 ways to protect somebody against relapse. One is to keep somebody on medications. The other is to give them exposure to cognitive therapy, and I'll later show you for behavior therapy, and let relatively short term and let them go with that. If you look on the right-hand side where it says follow-up, now about a year out, we're probably talking about recurrences, the onsets of wholly new episodes, rather than just the return of the last episode. And as you can see, there were many more patients with placebo condition that could have had a additional onset, although virtually all of them did. We're down to under 10% that survived the 2 years post-medication without having a relapse or recurrence. The medication condition, a little hard to tell exactly from this graph, but if I were to push the red and the green together at that slide, starting only with those folks that survived the first year without relapse, again, we have a significant difference favoring prior cognitive therapy in this instance, in this phase, with no booster sessions at all, over medications once they're taken away. The beginning of the continuation phase on the left side, you take medications away, the yellow line, and patients do less well than if they had prior cognitive therapy. In the middle of the phase, the folks that survived without relapse that had prior cognitive therapy, again, do better than the folks, now in this case, the red now dashed line, that have the medications taken away. Medications, as good as they are, only work while you take them. They have virtually no lingering effect that we've ever been able to detect. Cognitive therapy looks like it has an enduring effect. If we look at an index of sustained improvement, this is, does a given patient complete treatment, get well, and then stay well for the first year of that follow-up? These are the bars that we get. On the far left, this is the way we would have treated patients back when I first came in the field in the late 70s. We would put somebody on medications, and then once they were better, we would stop the medications. That's analogous to the patients that were treated with medication in the acute treatment phase of our trial, then withdrawn onto pill placebo, what I just showed you. And essentially, just a little over 15% of those patients completed treatment, got well, and stayed well over the course of the next year. Not great. If you look at the ADM followed by ADM, the red bar in the middle, that's our current standard of treatment in the field. That's what the American Psychiatric Association would say anybody with this level of severity ought to get. And what we see is about 1 patient in 3 completes treatment, gets well, and stays well. That's not great. Cognitive therapy does a little better than the active medication, not significantly. This is prior cognitive therapy. 16 weeks of cognitive therapy pushes, followed by the enduring effect, pushes up to about 40% overall sustained improvement. It's as good or better than the best the field currently knows how to do, and this is just over the first year. If we look at the costs, these are the direct costs that it costs us in the trial to provide either cognitive therapy, the blue line, or the medication treatment. What you'll see is over the first 4 months, the 16 weeks of acute treatment, it was about twice as expensive to treat somebody with cognitive therapy as it was with medication. It's a more expensive treatment. It's more labor intensive, particularly if you do it at the level of frequency that ought to be done. I know a lot of times folks, particularly in Europe, tend to back off and do it only weekly or less often perhaps, and I just don't think that's a good idea with patients at this level of severity. But if you do it at that level of frequency, it's going to cost about twice as much as the medications. However, you only need to do it for the, in this case, for us, for 16 weeks. After that, the costs pretty much level out, just the occasional little booster sessions, and they pretty much flatten out across times. With the medications, it's less expensive in the acute treatment phase. The problem is to keep people comfortably well, you have to keep them on medications. You can space out the pharmacotherapy visits, but the medication is still expensive. You can drop back to generics, and that'll cut your costs some, but eventually the lines are going to cross. And at least in our trial, before the end of the first year, it had ended up being more expensive to keep folks on medication, treat them with and they keep them on medication than it did simply treat them with cognitive therapy in the first place. Comparable efficacy, more enduring effect, and perhaps more cost effective over time. The next slide I want to show, the slide I just showed were the data from Hollon et al., which is in the middle of this step. But this is from a recent meta-analysis published by Pim Kuipers and colleagues. And what Professor Kuipers did was looked at the 8 studies that had contrasted, looked for the long-term effects of prior cognitive therapy vis-a-vis medication, which also wasn't continued. So we're going to be looking at cognitive therapy vis-a-vis active medications, where both are discontinued at the end of the acute treatment phase, akin to what I showed you a minute ago in the Hollon et al. Slide, with the green cognitive therapy line versus the yellow withdrawal into pill placebo. And what you can see from the slide is of the 8 relative comparisons, 6 of the 8 show an advantage for cognitive therapy over medications, and the 7th, the Shea study, the next to last at the bottom, comes very close to doing that. The only outlier is a very, very small pilot trial by Robin Jarrett, the follow-up to 1999 comparison of cognitive therapy with medications in atypical depressions. And it was a small study with under about 5 patients per condition. She's not sure she wants to bank money on that. But almost invariably, we have this nice enduring effect for prior cognitive therapy. Effect size is the odds ratio is about 2.6. So we're getting a pretty good size advantage for prior cognitive therapy versus prior medications. And for 6 of the 8 significant differences, 7 of the 8 really moving in that same direction. Even the collaborative, which tends to be a bit of an outlier, the Shea study moves in that direction. I think this is a pretty robust finding. It looks like if you treat people with either cognitive therapy or medications and you only keep it going for a fairly short period of time, we can really establish the enduring effect for cognitive therapy, and certainly much better than medication withdrawal. The next slide also comes from Kuiper's study, and basically in that trial, these are the 5 comparisons that have looked at prior cognitive therapy versus continuation medication, the thing that the American Psychiatric Association would say is the sine qua non of keeping people well. And again, the effect size, the odds ratio shrinks a little here. It's about 1.62, not as large, but it tracks, again, the same thing I showed you a couple minutes ago on the Hollon slide. It's prior cognitive therapy, a short-term 16 weeks of cognitive therapy is at least as effective, and when we aggregate across a meta-analysis, it looks like it might even be more efficacious than keeping folks on medications. It's at least as good and quite possibly better. If we had not that little small Jarrett study, the effect would have been significant. So it's I think, fairly impressive evidence for an enduring effect, which is at least comparable, perhaps even larger in magnitude, the effect of keeping patients on medications. Bottom line here, I think, is that question, does cognitive therapy have an enduring effect that reduces risk for subsequent symptom return? It looks like yes, and it's at least as efficacious as keeping folks on medications, and quite possibly maybe so. That's big. We've always hoped that psychotherapy would have an enduring effect, and at least for cognitive therapy, for depression, we have evidence that it probably does. Stop here for questions. Outrage?
Sorry. Yes, we have a question from William Lamb, who doesn't have a microphone, and asked, are there certain symptoms of depression, for instance mood, that respond better to cognitive therapy than to medication?
Yeah, probably not mood per se. And Jay Fournier has a nice paper in, I want to say, Consulting in Clinical, or maybe Brett, I forget which right now, it came out just the last year or two, that suggests that if you look at the symptom change across time, you just don't get big differences in the symptom change, at least in the size sample we're talking about here, between cognitive therapy and medications. Maybe a little faster impact on with the medications on mood, but it's pretty tenuous. And with respect to cognitive therapy, if you look at the vegetative symptoms, if you look at the atypical symptoms, you tend to get a better impact on hypersomnia with cognitive therapy. But of all the various symptoms we looked at, that's not a lot of yield for that. So you get some indications, but there's nothing really big there.
Okay, thank you. I have another question. It's from Susanna Romero. Susanna, your microphone is now open. You can ask your question. Looks like she doesn't have a microphone. Her question is, would you start with would you start CT only, or would you combine with medications?
Great question. Great question. As you know, we don't have a lot of studies that look at combined treatment. We generally have a lot of it being done. There are only a handful of studies, and they generally suggest a fairly small, modest advantage for combined treatment. So that if you're getting maybe a 60% response to either monotherapy, you push it up to about 70%. Little improvement, not huge. I've always in the past said that you retain the advantage of either single modality when you put them together. Medications work just a little faster. Combined treatment works a little faster than cognitive therapy alone. Cognitive therapy has an enduring effect, which medications don't have. You retain that in the combined treatment. Our most recent trial, which we haven't published yet, but we're working over the data now, begins to suggest that maybe we were a little premature. There were only 3 prior trials that looked for enduring effects in cognitive therapy combined with medications. A study we did back in the 90s at Minnesota was published, the FollowUp publishes Evans et al., where it got that effect, but about a dozen patients per condition, studied by Blackburn back in the mid-'80s. that was published that a little not clear. Maybe they got the effect, maybe they didn't. It was a little more, it was more ambiguous. And then a study by Ann Simmons, the follow-up to the Murphy study published in '86, where they didn't get the effect. So you got the enduring effect for cognitive therapy alone in Simmons, but not for the combination. Blackburn, you got the enduring effect for cognitive therapy alone, and it was much more equivocal in the combination. And then the Evans and al. trial, our trial, where you got the enduring effect for either cognitive therapy alone or cognitive therapy with provided in combination. It's made us much more nervous now. We see the data from the latest trial where we're getting an enduring effect that's maybe less than half, maybe a quarter of the effect size when we only provided cognitive therapy in combination with medications relative to cognitive therapy alone. So I'm starting to pull back a little bit. I'm not quite so confident that you don't lose the enduring effect when you put the two together. Bottom line for me is that, for non-psychotic patients, I'd always want to go with the patient's preference, but I'd be quite confident starting anybody that wanted on cognitive therapy alone and only bringing medications in if the person wasn't giving us a good response in a fairly rapid period of time.
Okay, thank you, Steve. That's it for the questions for now. I do realize that I forgot to ask you to turn your webcam on. We did do it in the trial, but could you try to put it on?
I'm muted.
You talking to me?
Yes.
Yes.
Okay. Turn my webcam on. Let me see what I have. I will do that, and I'll just let you guys know that I'm calling from home, so I would be in a relaxed and informal mode, and you might see the dog. Can you see me?
Yes.
Cool. Lovely. Proceed. Can I proceed? Can I advance the slides with the webcam on?
Yes, for sure. Can you click on the slide, and then you can probably proceed.
Okay, good. All right. Next thing I want to do is talk about moderation. And moderation basically is, are there given individuals who do better with either medications versus do better with medications or do better with cognitive therapy? We've shown you essentially tie-score about comparable acute treatment response, but that doesn't necessarily mean that all given individuals are equally likely to respond to the two. So I want to show you a couple of indications that we had of moderation from that particular trial. First one has to do with those patients that entered the trial unemployed. And we already talked about how cognitive therapy had a greater impact on employment than medications did, even though we had comparable rates of change in depression. If we look at the patients who were employed versus unemployed, you see on the left, if somebody was employed walking into the trial, and in this particular slide, down is good. This is Hamilton Rating Scale at 16 weeks is our index on the y-axis. So the lower the score, the better. Our patients who were employed did comparably well in the two modalities. Did 6 of one, half dozen of the other. Well, in this case, it's 7.2 of one, 7.2 of the other. For the patients who are unemployed, patients who are unemployed did much better in cognitive therapy than they did in medications, and that difference is significant. The outlier is the unemployed patients who only got assigned to the medication condition. They did significantly worse than the other patients. Either the unemployed patient got cognitive therapy or the employed patients, either way. One instance of moderation. You'll also see at the bottom, at the top of the slide in orange, there's a distinction between prognostic and prescriptive. Prognostic, a lot of times we look at predictors of treatment response. If we're not careful, we want to not fool ourselves into thinking that something which predicts response within a given modality necessarily tells you what to prescribe. For example, if you look at the medication conditions, the two red bars, you would have a prognostic relationship. You're much better off if you're much more likely to respond to medications if you're employed than if you're unemployed, but that's simply prognostic, doesn't tell you much. If you look within the two blue bars with cognitive therapy, you would say it doesn't make any difference whether you're employed or unemployed. Prognostic indices tell us which patient to choose to make a treatment look good. Prescriptive indices, which is what I just walked through, which is always the interaction of patient characteristic by treatment. In this case, it does make a difference whether you get cognitive therapy or not, but only for the patients that are unemployed. In that case, it's prescriptive for them. They would do better in cognitive medications. Employed, it doesn't matter. Another index of differential response in our trial were the number of life events prior to the onset of the depression. And on the far left, you have patients that had a small number usually none or no more than 1 or 2 negative life events prior to coming into the trial. And for them, it didn't make much difference which they got. And again, in this particular slide, up is bad, down is good. The red line is the regression line for the medication patients. The blue line is the regression line for the cognitive therapy patients. As you go across to increasingly more problematic life events that precipitated the depression, you get all the way out to the far right-hand side. Those patients that had a greater number of major life events that occurred that may have been precipitants for the depression did successively better in cognitive therapy than in medications. So again, we have evidence of moderation here. Number of life events, more life events being a predictor of differential response favoring cognitive therapy over medications. Additional moderating effect comes from the number of prior exposures to medications. And on the left, you see folks that got assigned to medications where they had no prior exposures, 1 prior exposure, or 2 more prior exposures. That was a significant predictor within that modality. It's prognostic within the medication condition. The more prior exposures, the less well you did on medications. On the right-hand side, didn't matter with respect to cognitive therapy how many prior medication exposures you had. And for patients with more prior exposures, the 2 more prior exposures, they did better in cognitive therapy than they did in medications. So it's another instance where prior treatment history might be predictive of what would be a better response to one modality versus the other. Now, you'll also see in orange at the top of the bar graphs where it indicates stable individual difference or tachyphylaxis. There are at least 2 possible explanations for this relationship, and it's a fairly stable relationship that's shown up in a couple of other trials as well. At least it's shown up fairly repeatedly in medication trials. The number of prior exposures predicts poor response, especially serotonergic medications. One is just that what we're doing here is weeding out, or what's happening in the past is that patients who are less likely to respond to medications get more medication exposures because you have to keep shifting medications, hopefully finding that something that works. So it may just be that we're picking up on an individual difference variable. The other possibility, and there's some other reasons to think that this might be the case, is something called tachyphylaxis. We know that particularly for serotonergic medications like the SSRIs, there's a tendency for patients who are stably responding to medications just to stop responding after they've been on the medications for a while. That's loss of response. There's also some evidence that prior exposures may, if you will, desensitize in a way that reduces the likelihood of responding in the future to serotonergic medications. In that case, it's a changeable process which would affect probably events at the synapse and the internal homeostatic regulation. We don't know which it is, but the data we have would be consistent with either. And we're a little concerned when we talked earlier about the enduring effect for cognitive therapy perhaps being undercut by putting together medications. We're a little concerned that we may be getting changes going on at the synapse for folks in medication treatment that work against the enduring effects that you might otherwise get from cognitive therapy. Next slide I want to show you is to point out that it's not always the case that it's cognitive therapy that shows the advantageous evidence of moderation. In this case, looking at the bottom of patients with or without personality disorder. On the left-hand side, we have patients who met criterion for 1 or more axis 2 disorders at intake into our trial. The PD means they have met criterion for 1 or more personality disorders, and about half of our sample did. On the right-hand side, we had patients that didn't. And what you see is here we've got a nice classic disordinal interaction. Patients that had an axis 2 disorder did better on medications than they did in cognitive therapy, 66% response versus 44% response. Patients in who didn't have an axis 2 disorder did better on cognitive therapy than they did in medications. In this case, virtually everybody you could make a prediction as to what their optimal treatment was going to be depending on what the personality disordered status was, but it went in opposite directions for different kinds of patients. When we want to see this replicated before we really want to make some decisions on it, when we showed these data to our psychopharm colleagues, what they said was, of course, that's what you would have expected. We said, wait a minute, you didn't tell us that at the beginning of the trial, otherwise we would have predicted it. They said, well, no, think about it for a moment. If you look at the animal literature, the 2 things that happens for animals that are put on antidepressant medications, particularly serotonergic medications, is they become less impulsive and less stress reactive. And when you think about what the operational definition is for personality disorder, these are people that tend to act out under stress. And indeed, the 3 major clusters, it was especially patients in the cluster B, the kind of impulsive acting out personality disorder kinds of styles that showed us the biggest effect. All showed it. We didn't have many folks with the cluster A, the kind of schizotypal personality disorders, but we and we had the most with the cluster C. The cluster C patients showed the effect. The cluster B patients, kind of intermediate numbers of them, they were the ones who showed us the biggest portion of the effect, which would be consistent with the animal literature. My colleague, Rob DeRubis, and students and his graduate students at Penn have developed what they call a personalized advantage index, something that allows for testing, and it's an optimization algorithm. They put together our various indices of moderation, our other prognostic indexes as well, and they do a relatively unique, novel way of putting these things together. There's something they call the leave one out approach, where they form their selection algorithms using the data from all the other patients except the given patient they're going to predict to. So they essentially form an equation for every patient in the trial based on all the other patients in the trial except that one patient, and then they put those together. It really goes a long way towards reducing shrinkage, so it's much more powerful way of doing this than the typical kinds of algorithm generation procedures. And what they estimate is, had they been able to assign patients to their optimum algorithm in the door, they would have gotten, would increment response by about as much as the drug placebo difference. The notion here being that you can improve the efficiency of your clinical practice just by knowing which patient ought to get which of the two single modalities. And it's still something that needs to be tested, and what I have in this slide is a demonstration how that would be tested. You would take the algorithms they generate or generate them in a new sample on the left-hand panel, and in the middle panel, what you would do is randomly assign a third of the patients to be optimized given whatever their algorithm would suggest, and see if you got a better response than you would from either the cognitive therapy above or the medications below. They do that hypothetically in their Gedunkens, their thought experiments, and the data come out exactly the way that you would have predicted, but we haven't seen the pure empirical demonstration of that yet. Bottom line, I think, is that even though on average we're getting about comparable response for cognitive therapy versus medications acute phase, of course we're getting quite a different response in terms of the during effect, but acute phase we're getting comparable response, we can still identify clusters of patients who do better on one or the other modality. And gee, it looks like it ought to be possible to put those things together and do an even better job of identifying which treatment is best for a given patient when they walk in the door based on these indices. Let me stop here and ask for any questions.
We have a couple of questions.
Sure.
Let's see. So there's a question by Russell Hilliard. He's not sure if his mic is working, but I'm going to try and open it, and we'll see. Russell, can you try and talk?
Yes, can you hear me?
Yes. Go ahead.
I was just wondering, this pertained, it was a question I wanted to ask about earlier, but any ideas, Professor Hollon, on if coming into the study of looking at data in terms of patients who were suffering from chronic depression versus non-chronic. There's a depression that lasted 2 years or longer, and how things might look different with a sample of people suffering from chronic depression versus non-chronic.
Unmuted.
Let me respond, but let me ask first, and Kim, if you could open up Professor Hilliard's mic again for a moment. Is that Russell Hilliard that I know, but we used to be at Vanderbilt?
It is, Steve, yeah.
Lovely, lovely. Good to talk to you again.
Yeah.
Basically, we did look at chronicity, and about a quarter of the sample would have met criterion for having a chronic episode. We looked at chronicity, and it was a prognostic factor. Patients did less well if they were chronic in either modality, but not differentially less well or not differentially well. So chronicity makes it into DeRubis's personalized advantage index, but it helps stabilize the estimates. It doesn't predict differentially one way or the other. You're no better off getting meds or cognitive therapy. You're just probably not going to do as well in either case.
Great. Thank you.
Lovely to talk to you. I hope things are well.
We have another question from Ed Wise. I'm going to open up this microphone right now. Ed, you can talk.
You made reference to life events moderating the response to CBT, but I was not clear on what those life events were. Can you give us some examples of what you were talking about?
Sure. Sure. Could be things like loss of job, breakup of relationship, difficulties within the family, fights with kids. We went through the I want to say the Holmes-Ray major life stressors, and we would pick up indices there and then follow up with interviews. Nothing quite as dramatic as the great London interview, not that intensive. We would follow up a bit, and on the life interviews at intake, we would note were there major difficulties, problems that preceded the depression. So it would run the whole gamut, the typical kind of things that people would run into.
So these were the Holmes-Ray items prior to treatment.
The index wasn't based solely on the Holmes-Ray. We used the Holmes-Ray as a screener and then followed up in the interview. So the kind of things would show up on Holmes-Ray, but that's not a Holmes-Ray score that we turned into that.
But based on events prior to treatment, not during treatment.
Based on events prior to treatment, and especially events prior to the onset of the episode.
Thank you.
We have another question from Mary Combs. I'm going to open up her microphone right now. Go ahead, Mary.
Yes, Dr. Hollon, can you hear me? Okay, great. Very interesting findings, and I'm wondering how would you compare the NIMH TDCRP study, which I believe found that with more severely depressed subjects, the IPT condition did better than CBT. So I'm interested in your study, I think helps expand the utility of CT with more depressed clients. But is there anything in a comparison of those studies that strikes you of importance?
Yeah, basically, I know the TDCRP quite well, and they had the 3 sites there. GW, George Washington, was one of the sites. University of Pittsburgh was another site, and University of Oklahoma was the 3rd site. And they didn't do a great. It wasn't they did a bad job of training, but they didn't necessarily get the best quality cognitive therapy done in the trial. Brian Shaw oversaw the training, good friend of mine and good fellow, but they wanted to have it be an effectiveness trial as much as more than an efficacy trial. So they limited how much training Brian was allowed to do, and they actually phased out the supervision for relatively neophyte cognitive therapists once the trial itself started. And they saw some deterioration in the quality of the interventions. Across the 3 sites, Oklahoma was where John Rush had gone after he left Penn, and John was the original cognitive therapy manual authors, and although they never reported in the article, they had quite different findings across the 3 sites. At the Oklahoma site, where they had experienced cognitive therapists in the trial in the first place, they did as well as they did with medications among the more severely depressed patients. At Pittsburgh and GW, where they didn't have therapists that were that experienced, they did no better than pill placebo. So I don't consider the NIMH collaborative being a particularly good representative of what cognitive therapy can do when you have therapists that know their business.
Thank you.
We have a question by Vidar Blokhus-Ekrol, who doesn't have a microphone, but asks, do you know about studies comparing long-term effects of cognitive therapy to other forms of psychotherapy? If so, what are the results?
I know of none. The only thing that comes close is the collaborative. They did a follow-up after that, and they didn't get, that's the Shea study, follow-up in '92, and they didn't get an advantage for prior cognitive therapy relative to prior medication, but it moved kind of in that direction. IPT was closer to the medication, but again, it's I think in all fairness, the collaborative, I wouldn't put much stock in it one way or the other, because as I mentioned, there were some site differences in the treatments for the implementation of cognitive therapy, maybe even a little bit of that for IPT, where Oklahoma probably wasn't the best site for interpersonal psychotherapy, but that's the only one I've seen that's really followed any other kind of psychotherapy out long term. The one I'll show you perhaps in a few minutes with behavioral activation is more purely behavioral intervention, and that we do get a long-term follow-up on, and it looks pretty good for behavioral activation. But that's about the only thing I've ever seen.
Well, thank you, Steve. We have no further questions at this point, so you can continue.
Unmuted.
Cool. Let me go on to mediation. And here we're talking about not who does better, does a given patient do better in different treatment, but as best we can tell, when we get a treatment effect, what are the processes going on that produce that effect? It's the theoretical question, how does the treatment work? And I'll say, what I'll say in the beginning is that what we've learned over the last, at least what I've learned over the last 20, 30 years, it's very hard to do an adequate test of mediation, particularly in terms of acute response. And my colleague at Penn, Rob DeRubis, has really laid out some of the parameters there. If there's anything to the cognitive model, and you ought to be able to get symptom change following cognitive change, we consistently get cognitive change in cognitive therapy, but we also get cognitive change in pharmacotherapy. And the temporal lags are probably extremely short, the kind of thing you'd have to get at with neural imaging, not with questionnaires. So we almost invariably get cognitive change in both modalities. Back in 1990, Drubus did a very nice follow-up to one of our earlier trials where he looked for the pattern of change across time, and what you got was a situation where cognitive change preceded change in depression in cognitive therapy and followed change in depression in pharmacotherapy, even though you produce comparable cognitive change across time in both modalities. And it's beginning to take a look that maybe it was indeed the kind of mediation effect that we would have expected from cognitive therapy. But the data there are just much tougher to make a strong inference from. It's not that they're not consistent with that, they're just not definitive along that way. With respect to the enduring effect, we can be much more certain about what goes on. The data I want to show here are a nice paper that Dan Strunk at Ohio State did following up on the study that I've already been talking about, the DeRubis acute treatment findings followed up by the Hollon longer-term follow-up. And what Strunk did was looked at two particular measures, looking at cognitive skill and both the acquisition of and the use of cognitive skills. And he looked at two particular measures as indicated along the bottom. One is the WOR, which is the ways of responding inventory. That's a set of hypothetical story problems that you give people to ask people to complete. Things like you lose your wife, you lose your job, you lose your dog. It's like a country music song out of Nashville, all these bad things. And you ask people, if that happened to you, first imagine what it would feel like and then tell us what you would do. And what you hope for, patients that have been through cognitive therapy would say, well, I'm going to get myself busy, I'm going to get active, I'm going to schedule my life, I'm going to do the things I would do even if I weren't feeling depressed, I'm going to pay attention to my beliefs, et cetera, et cetera, et cetera. And the bottom line here is that those folks that were better able to respond in those kinds of ways to those kinds of challenges do get better scores than the WOR. The second thing, the PCTS, is, I forget exactly what the abbreviation stands from, but it's actual ratings of the taped sessions. And in later sessions, what typically happens is people that have been exposed to cognitive therapy start taking over the sessions. And whereas the therapist was leading in the early session, in the later session, they come in and say, well, I ran into a difficulty at work, and my boss said this, and I felt this, and then I thought that, and then I did this. And essentially, they walk you through the topics. There are many cognitive therapists in the sessions. And again, patients that do better in that regard are the ones you would predict would do better in the follow-up. And indeed what Strunk found, it's the top row, the yellow, are the sustained responders, the bottom row are the red, the relapsers. And again, on a composite of those two indices, the folks in the top row that were higher scores were the ones who were less likely to the folks who didn't relapse showed higher scores at the end of acute treatment than the folks that did relapse, and also better than the folks that had the medication-only conditions. So that you have pretty good indication there that we're getting changes in those things which we expect to change in cognitive therapy, and they're predicting subsequent relapse across time in a way which is quite consistent with what you would expect from mediation. That's some other things which make us think that we're getting changes in the way that we would expect to, in the processes, the cognitive processes we would expect to. This next slide shows the sudden gain phenomena. This comes from Tony Tang's work. Tony, a former student of Rob DeRubis, is now at Northwestern and actually a citizen of the world. He divides his time between China and Hawaii and Evanston. And what Tony recognized looking at response to treatment in cognitive therapy was that some patients show a nice gradual response to treatment, session by session, week by week. They start showing this slow gradual improvement. Other patients show a phenomenon he labeled sudden gain, and it turns out about half the patients show the sudden gain phenomenon where all of a sudden, oops, I went a slide too far, all of a sudden they'll be going along and they'll show this big drop. It's like they fall off the table of their week by week scores. And when you get a big enough drop very rapidly, it tends to be sustained over time. You wouldn't necessarily think something that unstable would be sustained, but it is. And it also tends to be quite a good predictor of who it is that doesn't relapse. These are the data from the Hollon et al. Follow-up I just showed you earlier, now divided into the sudden gain patients versus the non-sudden gain patients, all of whom did comparably well. And what you see is it's the sudden gain patients that were particularly likely to show a sustained, enduring effect. Tony went back into earlier studies and looked at what was going on in the session preceding the sudden gain, and what he found is a great propensity for that to be the session in which the light bulb turns on. And the patient says, oh my goodness, it's not just what happens to me, it's how I think about it and what I do about it that really makes the difference. And when that light bulb clicks on, you don't tend to lose the light, and it tends to stay with you over time. So again, we think this has been consistent with the notion that when patients catch on to the cognitive model and begin to recognize they can use that to their advantage, they're not just the helpless, passive recipients of life's slings and arrows, but the things they can do about that. And a lot of times it's the way they look at the slings and arrows that affect, then they seem to pick up a relatively lasting, enduring effect. And again, we think that's consistent with the cognitive interpretation of how these things work. Bottom line, I think here, although it's really quite difficult to do an adequate test of mediation with respect to acute response, our change in cognitive indices is there in acute response. It's just it also tends to be there in pharmacological treatment. But with respect to enduring effects, in which we can separate the acquisition of the presumed mediator from the subsequent bad event, because they're usually separated by months in time, there we get pretty strong indication of mediation where cognitive change seems to be driving the wagon in cognitive therapy in a way that is not relevant for pharmacotherapy. Let me stop here for any questions.
We don't have any questions at this point. If people have questions, step to me now and raise your hand. We'll give them like a few seconds. No hands coming up. All right, I think you can continue now.
A little bit about behavioral activation. And I think of myself as somebody that learned years ago how to do cognitive therapy, which has very strong behavioral components to it. I have to say, if I had to balance between the behavioral and the cognitive components, I wouldn't want to have to talk a depressed patient out of their depression. However, my now deceased friend Neil Jacobson, died in the World Behaviors, thought that all of the cognitive stuff was irrelevant. All the cognitive efforts to help people address their beliefs was a waste of time, and he wanted to just be purely behavioral the entire time, and developed an intervention which he calls behavioral activation, which you don't directly address people's thinking at all. You do all the kind of things we would typically do in cognitive behavior therapy of the first 3 to 4 weeks, the more heavy behavioral focus, wrapped around a more purely behavioral case conceptualization. And in some respects, it is easier to sell a patient on life is tough than there's something wrong with their thinking. So at score 1 behavioral activation, they do something that goes beyond what Peter Lewinson and his students would have done 25, 30 years ago. They would have simply assigned people pleasant activities to do, but not everybody likes the same things. I love to go to movies. My wife hates to go to movies. For me, it would be mood enhancing, for her it would be mood depressing. So different people respond to different things. They do an actual functional analysis of people to find out what it is that actually is reinforcing for them, and that's what they encourage them to do more of. So it's a more advanced version of behavioral therapy than used to be the case, and probably pick up something there. They do a lot of activity monitoring and scheduling, just as we would in the early weeks. They really emphasize dealing with avoidance patterns. If there's something that somebody used to enjoy, they're not doing because they're worried, they're embarrassed. For example, there's a classic example of a fellow that started dating a woman at his work. They would go out together, they would go out with friends after work, etc., and they got very close. And then after a period of time, she broke up with him. He stopped hanging out with his friends because she might be hanging out with the same group of people. In behavioral activation, and the reason you can't do it in cognitive therapy as well, they would directly approach that, have the person do exactly the thing that they were most afraid of doing, following Marshall Linehan's great analogy of opposite action. Anything that if you're depressed, you don't feel like doing something, that's exactly the thing to do, and it works for behavioral activation, works for therapy as well. And with respect to rumination, they simply ignore the content of the cognition entirely, and they get the person to focus on what's going on in their life circumstance right at that moment. If you're at a backyard barbecue and you're ruminating about how tough it's going to be work the next day, smell the smoke, taste the flavors, throw yourself back into conversation with people, get out of your head and get back into your life. And again, they do a nice job with that. But it's a lot of what you do in cognitive therapy, but it's none of the cognitive stuff that you do as well. And the question is, can you get comparable results with a more purely behavioral approach? Their design was virtually identical to the Penn-Vandy study I showed you earlier, with the exception of the top row. They added a purely behavioral activation condition. Everything else is the same. Cognitive therapy in the second row for 16 weeks with follow-up evaluation, medication, also, in their case also paroxetine, with a second randomization at the end of the acute treatment phase, either taper to placebo or continue on Paxil continuation. Then a placebo control only only 8 weeks as in our previous trial. So identical trial from the bottom 3 rows on, with the different top row behavioral activation. And the other difference was they included the full range of patients with major depression, less severely depressed and more severely depressed, but otherwise identical to our trial in virtually every respect. This is what they got. Here we're going to be looking at BDI scores, and up is bad, down is good, and we're going to divide into 2 groups of patients. Those with less severe depressions, the dashed lines along the bottom set of 4 outcomes. And the top 4 lines are the folks with more severe depression. The top 4 lines, the solid lines, would correspond to the patients already showed you in the Penn-Vandy trial. In the bottom set of rows, the patients with lines, the patients with less severe depressions, what you see is it didn't make a dime's bit of difference what you did. Behavioral activation worked as well as cognitive therapy, worked as well as antidepressant medications, and worked as well as pill placebo. Pill placebo worked just fine for those folks. Virtually identical pattern response that they had in the NIMH collaborative. The more severely depressed patients, it did make a difference what you got in this particular trial. Medications worked fine, behavioral activation worked fine, cognitive therapy did poorly, no better than pill placebo, and was different from the other 2 active conditions by the end of the acute treatment phase. Again, virtually identical to the findings we had in the collaborative. In this case, I think like the collaborative, although these were good therapists, they weren't that experienced with cognitive therapy, and there were limits to how I did some of the supervision. I did all the supervision and training along with Keith Dobson, but there are limits to how rapidly we could interact with them. And a typical supervision case, they would have to tape the session, they'd have to copy the tape of the session, have to mail it to us. So usually we're running about a week or 2 behind the sessions. You might have 2 or 3 sessions before you got back with the supervision. Not the ideal way to do the supervision for the trial. In our trial, we would have additional training for the therapist. They didn't do the additional training. Again, you do different things in different kinds of studies, and I think the poor response of cognitive therapy can be explained away, but the good response to behavioral activation can't. It did really quite well in that trial, and it would suggest that my friend Neil was correct that you can do virtually anything you can do with behavioral activation alone that you can do with cognitive therapy in the acute treatment phase. I'm going to skip this now and say just a word about this slide. It turns out that the difference between the cognitive therapy and the other 2 conditions is almost wholly accounted for by, if you look all the way the next to last bunching on the right, there was a small set of patients, about 10, 12 patients did extremely poor cognitive therapy. The rest of the response was pretty much the same, but there were extremely poor, extreme non-responders, and those were basically folks who had were tough to get along with, had access to disorders, similar to the folks who did poorly in our trial. We didn't do that poorly with them, but in the Seattle trial, they accounted for the bulk of the poor response for the cognitive therapy group. I move on to the follow-up from that study, and basically we've got with this virtually identical design to what we had in the prior Penn-Vandy study, with the exception that there are no booster sessions allowed, and in this case also this sample involves about half the sample are less severely depressed. They shouldn't be as a greater risk, and we see that the overall lines are pushed up a little bit, but those folks that got better on medication and then withdrawn onto pill placebo, the yellow line were the ones that had the greatest rate of relapse over the first year. The red line are the folks who were kept on continuation medication. Indeed, we had a visible difference. It wasn't fully significant, but again, it looks like something that looks like a continuation effect. If you get better on medication, stay on medication. The green line are the folks that had the prior behavioral activation, and they did at least as well as the folks who stayed on medication. No great difference, started to tail off a little bit at the end, but did basically as well as the folks that had prior cognitive therapy, who did as well as folks who were kept on medication. That was one condition that did significantly better than the prior medication condition, the yellow line, but the behavioral activation line, the green line, was virtually identical to it. By the time you get to the second year, when you take the medications away, again, it's like dropping those people off a table. Prior behavioral activation, prior cognitive therapy, those patients continued to do better. They both show what looked like an enduring effect relative to the medication withdrawal. Again, very similar pattern in terms of the sustained improvement to what I just showed you earlier from the Penn-Vandy study. Virtually identical rates of about 18% sustained improvement for the folks who got medication and then you took it away. About 30%, 32% sustained improvement for the folks who got medication that you kept them on. That's, again, our current standard of treatment. And then about 37% for the prior behavioral activation, only 16 weeks of behavioral activation, and up over a little over 40% for the prior cognitive therapy. You could almost have graphed these findings, sustained improvement findings, on top of the ones from the Penn-Vandy trial. It gives me some confidence. Cost, very similar kind of thing for either behavioral activation or cognitive therapy, about twice as expensive in the acute treatment phase, but you make up the costs over time because you get the enduring effect. It looks like it's cost effective. Bottom line for me is it looks to, I want to see this study replicated. I want to see it done somewhere outside of Seattle. I want to see it done where behavior therapists aren't the ones that wrote the manual. All that being said, it was a very strong initial effort for behavioral activation. And if you get replications, then it makes me think that you can do virtually anything that you can do with cognitive that you can do with behavioral activation. And if that's true, it's going to be a simpler, easier treatment. It's easier treatment to deliver. I want to see the replication, but the thing I would say at conferences, I'm one replication away from a conversion. It just is impressive first run for this intervention. I think Frank Peters, Marcus Hubers, and colleagues worked with colleagues in Iran that recently published a trial looking at behavioral activation vis-a-vis medication. In Iran, I think it actually beat the medication, although the medication condition was probably not fully dosed, probably about half the dose they should have had. So it's at least a placebo effect. So it's another good outcome for behavioral activation in a fully clinical sample. I'd have to say the impressive early findings for behavioral activation, particularly with respect to a possible enduring effect. Let me stop here for any questions.
We have a question from Mary. Again, Mary, I'm opening your microphone.
Okay. Dr. Hollon, I'm just looking for a takeaway, and you're a very fast speaker. You cover lots of territory. I'm a little confused still about what you're saying about CT and behavior therapy, and what what are the ingredients that you think are most related to good outcome.
Gotcha. Cognitive therapy, despite the name, is not purely cognitive. There are a lot of behavioral elements to that as well, and it's really a cognitive behavior therapy. The reason it's called cognitive therapy is because it's based on a cognitive model. I assume that the reason people are getting better is because we're changing their beliefs, but we would say that one of the most effective ways to change somebody's beliefs is get them in a situation where they find out it's not true. Behavioral activation pays no attention to the beliefs. It'll get them in the situations, pays no attention to the beliefs either before or after. And again, my friend Neil Jacobson would say he thinks we are diluting the quality of the intervention by putting all that cognitive stuff on there. I wouldn't go that far, and I really need to see the replication of the enduring effects before I'm going to be confident behavioral activation produces long-term enduring effects. It kind of did in that one trial. They were starting to fade near the end. I'm not persuaded yet, but if I see that, then I'll start thinking, my goodness, maybe we are doing a lot of unnecessary attention to cognition. I'm not there yet, but good showing for behavioral activation first time out. They overlap more than they differ on the behavioral side, but the behavioral activation approach pays virtually no attention whatsoever to cognitions other than to get you to stop worrying about them and to do something.
Does that answer your question, Mary? Steve, we have about 10 minutes left in this webinar, so I wanted to ask you if you either want to go to your sort of final points and then we'll go over to the general discussion for a few minutes, or whether you want to go into the general discussion straight away. Sorry.
Final slides. I think do people have the copy of the slides, by the way?
They don't.
As far as I'm concerned, welcome to make the slides available to anybody that's part of the webinar. The only things I was going to show were the lovely slides from Eric Turner that suggest that as good as the medications are, they're not as efficacious as we think they are. A lot of that's boosted by publication bias, where we only see the trials that get positive effects in the literature, so we tend to overestimate how good they are, but that's also true for the psychotherapy, so it's a pox on both houses. And the other thing I was going to suggest is that the findings we saw from the behavioral activation study, where for less severely depressed patients, it doesn't really matter much. Anything you do is going to be better for them than nothing. Anything works better than nothing. Nothing works better than anything else. You have to get up to more severe depressions before you start getting specific effects, and that holds for medications, it holds for cognitive therapy, it holds for behavioral activation, virtually any psychotherapy that we've seen. And the question is whether any other psychotherapies beyond cognitive therapy, behavioral activation, and IPT actually have specific effects that we have no evidence of yet, but could still turn out to be true. So given that, I think we can go right to general discussion.
Okay, great. So people, if you have questions or points or discussion points you want to raise, please either raise your hand or type in your question. Yeah, I see we have a question from Susanna Ramiro, if I remember correctly. She didn't have a microphone. And she asked, could you please recommend research on depression concomitant to clusters?
Unmuted.
Clusters. I'm not sure what clusters means. Is that groups?
I'm not entirely sure either, so Susanna, could you check that? She means personal disorder. Clusters.
Still not following means, what's the term?
Steve, I think she means cluster A, B, and C for personality disorders. They're sort of comorbid personality disorders with depression.
Right, yes. I've not seen much looking at personality disorders at all in our particular trial. We broke it down in terms of, our overall effect was based on any personality disorder, but we could go down and break out the three kinds of clusters. If you recall, cluster A consists of things like paranoid personality disorder, schizotypal, schizoid, etc. And the things that look more like the psychotic disorders, we didn't have many folks that met criteria for that. I think only about 4% of the sample. Virtually none of those patients responded to treatment in the first place, regardless of what we did with them. So they're rare and they're tough to treat. But not differential as best we could tell. It's just had too few to get a look at that. The cluster C are the things that look like neurotic disorders, avoidance, passive-aggressive, I got a block on some of the other terms, but they're the things that dependent personality disorder, the things that people tend to feel badly, but they don't tend to annoy other people as much. In that sense, they look more like a neurotic disorder, and they were our largest cluster of things. Probably about a third of the patients that met, probably about a third of the patients in our trial would have met criterion for one of those axis 2 disorders, usually multiple disorders, and they showed that ordinal effect where they did better on medication than they did in cognitive therapy, but it wasn't huge. The patients that were constituted about the other 15% of the sample, the remaining personality disorder patients, were the patients with cluster B disorders, narcissistic, antisocial, though we tried to screen antisocial out, 1 or 2 slipped in. Borderline, we especially tried to screen borderline patients out, but about 5 or 6 slipped in, and they were the folks who just did better on medications than cognitive. They showed the biggest differential advantage for medications over cognitive therapy. Again, I want to see it replicated before I make too big a deal out of that, but it was pretty dramatic in our data set, so, and I haven't seen other people look at that yet, although I'm sure now that it's out there in the literature, people are going to be starting to. I take that back. There's one study, either the Canadian study or the Australian study, it might be Joyce, where they had some indications of advantage for, went the other way, advantage for cognitive therapy relative to IPT, but again, that's different from the medications.
Okay, I have a question from Todd Leiber.
Oh, can I talk? Oh, I can talk now. Okay. Yeah.
Yes.
It's less expensive to make a competent pill of Paxil, so to speak, than to make a competent CBT therapist, and one who can sustain their skills, you know, not have that drift that we hear about. And I'm wondering, to be practical, it seems like there needs to be some kind of research or something done to identify a level of CBT that's just good enough to compete with pharmacology. I wondered if you could speak to that.
Unmuted.
Sure, and that's a great question and a very reasonable question to ask. Well, it turns out that we don't get a moderation of enduring effects. So even though you get a tie score with the less severely depressed patients, cognitive therapies as good as medication, et cetera, and it was even in the Seattle trial and in the NIMH collaborative where the quality of cognitive therapy wouldn't have blown you away, you still get enduring effects for those patients. And so that the long-term benefits you get regardless, you don't have to have a high level of competence for the therapist. You probably need that to get the really tough, severe chronic morbid patients better. But for the run-of-the-mill major depressed patient, that's probably not necessary. So my hunch is that you don't have to have absolute sterling quality of cognitive therapy to get there. You might have to keep up with medications in the more severely depressed patients. The second thing I would say about that is that patients get better with practice, therapists get better with practice, and you don't necessarily have to have drift, particularly if you're talking to colleagues on a regular kind of basis. I had a child of the 60s, and I'd never think of supervision as being the key as much as consultation. What I would always do with my colleagues is go over our cases with one another. I might set aside an hour or two a week or an hour or two every other week to meet with my colleagues. We'll watch each other's tapes, not at great length. We'll watch things, we'll comment, etc. And the best way to keep ourselves good with the approach is to watch and give feedback to one another. You don't need to have a top flight supervisor to do that. And I learned that kind of thing raising a child. If you've got a 3-year-old at a playground, for God's sake, talk to the other parents. Just if you spend the entire time dealing with a 3-year-old, you'll get soft in the head. And the same thing happens to cognitive therapists. They're only trying to be a therapist with tough patients. So I think there are things to do. I'm struck by the fact the problem with medications, as good as they are, is they only work as long as you take them. The thing we know about depression is it's a chronic, lifelong risk factor. And there is no time at which it's ever safe to bring somebody off medications. In the States, we're increasingly moving to keeping patients on medication for the rest of their lives. We're treating depression, anybody with chronic or recurrent depression, good pharmacotherapists is never going to bring up coming off medications with that patient because there's no time at which they ever drop below a 3 to 5 times greater than the average population risk. In England, they have a single payer system, National Health Service, where the country is going to bear the cost of treatment, both in terms of the direct costs, in terms of the loss of productivity, employment, et cetera. They've invested £700 million in training therapists how to do cognitive, behavioral, and interpersonal interventions, the psychotherapies that have shown to have legs and in controlled trials, just because they know that the future is not on the side of providing medications. You have to keep doing it over a lifetime, even when you go to generics.
Steve, I have one. Thank you. I'm going to ask one final question myself, and that is, what do you think would be the next thing that we need to study in this field, sort of the new thing that if you were to create a new trial, that would be definitely
Yeah, if you do things in terms of patients' characteristics, I think that the whole notion of transdiagnostic approaches is just quite sensible. If I look at our depressed populations, really we have 2/3 of the folks are really neurotic who get depressed under stress, and about 1/3 of them probably have something else, maybe hidden bipolars, other kinds of things. My wife and I are good examples. Lovely lady, but she gets depressed when she gets stressed. I get depressed when I get bored, and we both show depression, but mostly in the past. In my case, because I've done a lot of cognitive therapy, I just can't sustain the depression. In her case, because she married well. I mean, I think the things we ought to be able to do for neuroticism, which cut across diagnostic categories, and building on some of the things that we do for the different populations, bringing those together, I think is a very good idea. I'm just back from Oxford last week, and the kind of things somebody like David Clark can do. He's virtually solved panic disorder and on the verge of doing that for social phobia. Healer is doing the same thing with respect to PTSD. They're just marvelous things going on. Marshall Linehan with borderline. I think they're transdiagnostic approaches that we can take, which are going to push the field forward in very interesting kinds of ways. In terms of, that would be the main thing I think I would point out.
Okay, thank you, Steve. We're out of time, so we're going to stop this webinar. I want to thank you for your very interesting talk. For the viewers who are here, I want to point out that on May 5th we have our next webinar, which is going to be with David Orlinsky. So feel free to attend if you're interested in his work. I also want to point out that this webinar has been recorded and will be posted on the SBR website. If you are an SBR member, you can watch it or rewatch it over there, or even download it. So. that's it for us for now. Thank you all for being here.
Thanks, folks.